Hi everyone, I'm Shanley Treleaven and I'm here to give a little guest lecture on the treatment of stuttering. So when you first think about treatment of stuttering, you think, is the client younger than age 6 years or older than age 6 years? And why is age 6 the magic number, you ask? Well, this is because that is the age by which most children recover from stuttering if they're going to recover from stuttering. And when I say recover, I mean spontaneous recovery. We really have no way to predict this. We have no great way to see which children are going to recover and which aren't, but about 75 to 80% of children who stutter who are younger than the age of 6 do stop stuttering by the age of 6. This can be predicted a little bit by gender. Most, or not most, but more females recover from stuttering than males. Family history, so if you have a parent or some family member who recovered from stuttering, chances are that child will too. But these aren't great predictors, so keep in mind when you're working with a child below the age of 6 that there's still that 20 to 25% chance that they're going to persist in stuttering after age 6. And the reason you want to keep that in mind is if you tell the family, oh, your child will definitely stop stuttering, well, that's not necessarily the case. And if the child doesn't, then that can cause more harm than good later on. You don't want the family to be disappointed in the child or blaming the child. This is not a scenario where if the child works hard enough in therapy, they're going to stop stuttering. This recovery is spontaneous. And then if the child is older than 6, or if they're 6 or older and they are still stuttering, they're going to persist in stuttering for the rest of their lives. Again, this isn't something they can overcome with therapy, so you're going to help them with stuttering, but you're not going to use speech therapy to cause them to stop stuttering. So in children who are stuttering at a younger age, whether they're going to recover from stuttering or not, you can give indirect or direct therapy. And you might ask, well, if 80% of them stop stuttering by age 6, why treat them at all? Well, why do you take an aspirin for a headache? It helps. So you're helping this child with their speech, even if they're going to spontaneously recover. And when we say indirect and direct therapy, we mean, are we directly addressing their stuttered speech? For instance, for indirect therapy, we don't directly address their stuttered speech until after the age of 6. So the Palin approach is an approach out of England that is very family-focused, and so is the family-focused treatment that came from Yaris, Coleman, and Hamner. And in these treatments, essentially, you are reducing environmental stressors placed on the child. So according to the demands capacities model, which is a Starkweather theory of stuttering, the demands placed on the child to speak fluently outweigh the child's capacity to do so. So these demands might be internal stressors, such as a child being very perfectionistic, maybe they're comparing themselves to others, or maybe external stressors such as a very loud and noisy environment, or parents that are talking very, very fast around the child. Maybe they don't have a routine that they can expect at home. So there are a lot of different examples of external stressors that can be placed on a child that can be addressed in indirect therapy. One thing you're going to see a lot of is parents that say, oh, well, my child wasn't stuttering, and then we went to Disney and the child started stuttering. Well, that's a lot of external stressors on a child because there's a lot going on at Disney, and they're having a lot of fun. External stressors aren't necessarily bad. They're just a lot of stimuli that could be diminishing the child's ability to speak fluently. That's all. I'm not saying don't take your children to Disney. The same thing for a new school. A lot of parents say, oh, well, my child wasn't stuttering, and then we changed to a new school from maybe a preschool to an elementary school, and they're stuttering. Well, they don't know what to expect as well, and that could be an external stressor. So ways that you conduct indirect therapy is counseling the family on maybe helping a child have a routine for what to expect, or helping them with some of those external stressors that are unexpected, like getting in the routine for school, letting them know what to expect if there is a change coming up, slowing their speech. So a lot of that noise that can hurt a child's fluency is if a parent is super rapid with their own speech, or if they don't at least wait a beat after they're done speaking to make sure a child's able to get everything they want to say out. So the parent needs to not talk over their child, which it's an adjustment if your child is stuttering, because they might have a moment of disfluency and the parent thinks they're done speaking, so the parent goes ahead and talks when the child's trying to still speak. So giving a gap between the child's speech and the parent's speech can be very helpful. So there are a lot of different kind of indirect parts to this therapy that can help a child speak fluently. And this doesn't hurt any child. So if your child that's your client recovers from stuttering, this hasn't hurt them. Establishing a routine, reducing stressors, reducing the rate of your speech to help them speak isn't going to hurt anybody. Direct therapy, however, and this is also helpful, so keep in mind indirect and direct therapies are equally effective, deals with the speech directly. So in the LidCom program, one comments 5 times on smooth, fluent speech for every 1 time the parent comments or the clinician comments on bumpy, and I use air quotes here, bumpy, stuttered speech. So with a LidCom program, you have to wait for 5 times you've talked about their fluent, smooth speech. And then if they have a moment of stuttered speech and you've already commented positively 5 times on fluent speech, then you can say, oh, hey, that was a little bumpy. Let's try that again. And be very neutral. You're not negative. Please don't be negative about their stuttered speech, but you can be neutral about it. You can offer, hey, let's try that again, or we can do this together. Let's say it together and help the child out a little bit. So that's the LidCom program. I prefer indirect therapy. I love the LidCom program, though, for parents who are constantly commenting on the child's stuttered speech, because that's a great evidence-based reason to tell a family, hey, let's limit the amount you comment on their stuttered speech. So that can be a good tool in your toolbox as a clinician. This is just a really good graphic for indirect therapy, and this is showing kind of the bucket overflowing. So if you have too many demands on the child, their bucket proverbially overflows, and it can contribute to stuttering. And this is not what is necessarily causing stuttering, because stuttering is something we consider multifactorial, meaning there are a lot of contributors to stuttering. But stuttering is certainly exacerbated by these external stressors, so reducing them can help. And make sure to be clear about this with families, so you aren't saying, oh, well, by you not having a routine, you cause stuttering, or you going to Disney caused stuttering. That's not the case at all, but you can help it. Again, it's like giving an aspirin to someone with a headache. You can help it. And make sure you're clear with families about that, because if families believe they're causing stuttering, they're going to get defensive and shut down and not want to do therapy the way you encourage it. Okay, so if you know the child is going to persist in stuttering, you want to use stuttering modification or fluency shaping techniques. Stuttering modification is something that Van Riper came up with in the 70s, and it involves helping modify a moment of stuttering. We call this the struggle-free approach. So this is an approach you use not to keep someone from stuttering, but to help them not struggle as much with their stuttering. So the first step to stuttering mod is identification of stuttered speech. So have they identified when they are stuttering, in what situations that they stutter in? And then next, we want them to desensitize themselves to stuttering, because if we want to help them smooth out a moment of stuttering a little better and help them have a little more control over their speech, they can't be terrified of stuttering, okay? So if we help desensitize them to stuttering, maybe take some of the fear out, then we can help them move on to the last part, which is the actual modification of stuttered speech. And I do want to point out that the desensitization to stuttering and identification of stuttered speech are known to be a little bit more helpful in stuttering therapy. Because think about quality of life. If someone is going to stutter and you help desensitize them to stuttering, that really will help improve their quality of life, even more so than if they speak fluently or not. Fluency shaping is a technique where the person is supposed to never stutter. So this is complete elimination of stuttering. So where stuttering modification means being struggle-free, so take that struggle away from stuttering. Fluency shaping is stutter-free. This is when you're telling someone never stutter at all. And there is still a place for this in stuttering therapy. We use fluency shaping with people who neurogenically stutter. So maybe they're stuttering because they had a stroke or head injury. Stuttering modification is what I would recommend more so to people who developmentally stutter. So they've been stuttering since they were young. And it does have a fluency shaping component. So stuttering modification includes fluency shaping in this modification of stuttered speech. But this isn't saying don't ever stutter. This is saying here's a technique to help you be more fluent when you want to be more fluent. So as a clinician, you can make clear to your clients, it's okay to stutter. Here's some tools you can have in your toolbox for when you want to be more fluent. Maybe you're talking to a boss, or you're in an interview, or doing a radio show. You can have tools to help, but make clear to them it's okay to stutter and that they're going to continue to stutter, which is why, again, that desensitization to stuttering is so important. Which brings me to self-advocacy and self-disclosure as a person who stutters. And I use a study from Hope Gerlosh from the University of Iowa as an example. Even with the techniques we've talked about and education of families, people who stutter on average do earn less money than people who do not stutter, from this study from Iowa. And it shows that women who stutter earn less money than equally qualified women who don't stutter, showing some discrimination specifically against women who stutter, and that men might be discouraged from pursuing job outlooks that they might want. So the men didn't reach as high levels of training and education as men who didn't stutter. And we don't want people who stutter to be limited by stuttering. Because they stutter does not mean they have to pursue a career where they don't speak. We want them to do whatever career they like, whether that is public speaking, which plenty of people who stutter do publicly speak all the time and do a fabulous job of it. So as SLPs, we can encourage them to self-disclose that they stutter, which is key because self-disclosing helps tell whoever the person is speaking to, hey, I'm an individual who stutters, and it puts them at ease. So they know what's going on. And self-disclosing can also lead to self-advocacy. So a person who stutters can tell someone, hey, I stutter, and this isn't my fault. This has nothing to do with my IQ. No, anxiety does not cause this. No, it is not going to keep me from doing my job. And advocating should be able to help, or at least help contribute to decreasing this gap, this wage gap between people who stutter and people who do not stutter, because it is important that we as clinicians encourage the highest quality of life for this population and keep them from being limited. And a huge part of that is people who stutter self-advocating for themselves. And you as clinicians can encourage that. So you can really make a difference with this population. And clearly, because that article on this wage gap is pretty young, that was only 2 years ago, we have a little ways to go. So you can be a part of this as a speech-language pathologist. So thank you for listening. If you have any questions, feel free to contact me. I should probably put my contact information up here for you, but I appreciate the time. Thank you.